Good morning and welcome to Pediatric Grand Rounds. I ask that everyone in the audience please mute their phones. And this is one of our resident presentations. So we have a faculty mentor. She's upset that I'm here because I will steal all her jokes, but I'm not a very humorous person. So I will leave that to her, but I think everybody knows Dr. Widener, and so I'm not going to make the Clemson jokes I usually make and all that other. But after she went to MUSC, she did her residency at Kentucky, where she was chief resident. And after that, she went to UAB, where she did her pediatric infectious disease fellowship. She's been involved in many things besides being an ID physician. She was involved when we had a major eating disorders outpatient program here and was their medical director and their physician. So she has an interest definitely in our topic today. Dr. Widener, you're on for the jokes.
All right, thanks everybody. I was supposed to introduce myself, so I was going to say I went to the prestigious University of Clemson. And then, yeah, so I have no absolute, I did want to disclose, I don't have a background in eating disorders or adolescent medicine per se, but because we always have new people rolling in and I precept these eating disorder talks from time to time, just to bridge the gap. When I started here in 2012, we had a fledgling residential eating disorder program in town. And being the new person and the yes guy, I took on the role of the medical consultant there. So I learned a ton and I worked with this amazing multidisciplinary team out there. And so for several years, I got firsthand apprenticeship, I guess you could say, knowledge about working with the team for eating disorders and working with patients with eating disorders. And so I really enjoyed it. And I've kind of had a small pulse on it ever since, but it's been a long time now and my pulse is getting a little thready. So we did ask, when Kayln asked me to help precept this talk, I did ask Dr. Guyton, our adolescent colleague up in Greenville, for some background information as well. So I'm going to introduce Dr. Guyton, who's on Zoom with us. He is MedPeds trained and then adolescent fellowship trained, and he's our division head of adolescent and young adult medicine up in Prisma, Greenville. So he is an amazing resource for all things adolescent. And then, without any further ado, I'm going to introduce Dr. Stensrud. She is presenting a very jam-packed talk on eating disorders, and she talks fast, so y'all have to hold on to your coffee. But she came to us from Minnesota. She graduated from Ball State undergrad and then got her Doctor of Osteopathic Medicine at Des Moines University, and then has been with us in residency and has a job secured back in Minnesota when she leaves here with general pediatrics. And then I love her CV because I just have to say her work experience prior to undergrad, during undergrad, all kind of mixed in her young adult life includes swim lesson instructor, substitute teacher, gymnastics coach, vegetable production leader, nanny, lifeguard, receptionist, and my favorite, road maintenance worker. So I love a person with good life experience. So without further ado, Dr. Stensrud.
Thank you, Dr. Widener. So as she said, I have a pretty jam-packed talk about eating disorders today. So we will go ahead and get started. So my title is When Food Becomes a Foe, Improving Eating Disorder Outcomes Through Early Detection and Evidence-Based Treatment. All right, so objectives: increase awareness of the wide variation and presentation of eating disorders, increase awareness of the treatment options and pitfalls for eating disorders, and then understand the evidence-based medical inpatient treatment recommendations for patients needing medical stabilization for their eating disorders. All right, question number one. We all know there's questions, right? So which of the following is not a DSM-5 criteria for anorexia nervosa? Fear of weight gain. Oh, hold on, let me find the polls. All right. B, amenorrhea, C, significantly low body weight, or D, disturbance in how the patient perceives their body weight or shape. Can you guys see the poll? Maybe. Interesting. All righty. And next question. All right. The best approach for an inpatient medical stabilization of a medically compromised patient with an eating disorder includes start caloric intake low and go slow. B, place an NG tube immediately and start continuous feeds. C, give observed balanced meals with incentives for completion. Or D, check. All right. And third and final question, atypical anorexia is less serious or dangerous than anorexia nervosa. True or false? All right. Okay. So as far as disclosures go, I unfortunately have no financial disclosures, so that's fun. However, it is National Eating Disorder Awareness Week, and so I did not necessarily realize that when I realized that my grand rounds was this week, but super happy coincidence. So the National Eating Disorder Awareness or National Eating Disorder Association picked this year for a theme, strength through experience and knowledge by recognizing that it's time to change, alongside other mission-aligned organizations, and specifically stated that it's an opportunity to center on lived experiences in eating disorder education, which are the essential catalysts for awareness and change. So in full disclosure, many of you know, but I have a history of an eating disorder. And so that's a lot of the place where my passion for this topic comes from. So just if there's sprinkles of real world stuff sprinkled through here, that's where it came from. All right, as far as roadmap for today, we're going to talk about why eating disorders matter, a rapid review of eating disorder diagnoses, detection, treatment overview, and inpatient stabilization. So why do eating disorders matter? So busy prevalent slide here, but the estimates vary widely. There's a lot of perceived underdiagnosis of eating disorders. So according to the DSM-5, the 12-month prevalence of anorexia nervosa is 0.4%, and of bulimia nervosa is 1 to 1.5%, with an estimated 10 to 1 female to male ratio. Other sources have stated that the bulimia nervosa lifetime prevalence of 4 to 6 out of 200 females, and anorexia is 1 out of 200 females, with 95% of those with an eating disorder in the age of 12 to 25, which makes this super relevant for pediatrics. Overall, over 29 million Americans will experience an eating disorder in their life, which is approximately 9% of the population. Things that I wanted to point out from this graphic over here, the arrow is recognizing that the time spent on social media websites increases the likelihood of developing an eating disorder, which could be a whole grand rounds in itself, but we won't talk about today. Interesting to note that the average woman in the United States is 5'4" and 140 pounds, and the average female fashion model is 5'11" and 110 pounds. And then down on the bottom right, it talks about in children. So 80% of all 10-year-olds are afraid of being fat, and 42% of 1st through 3rd grade girls want to be thinner. As far as cost goes, so 3.3 million healthy person years are lost annually to eating disorder related disability. In the USA, patients with an eating disorder have a 48% higher yearly healthcare cost than those who do not have eating disorders. And overall, it's $64.7 billion cost annually in the US. And that includes direct treatment costs, direct financial burden, and then loss of earnings for patients and caregivers associated with treatment or missing work because of their illness. As far as mortality goes, the crude mortality rate for anorexia nervosa is 5% per decade, and that's usually due to medical complications or suicide, which has been estimated to be up to 50% of the deaths. And the suicide risk is 12 per 100,000 per year for those with anorexia. The crude mortality rate for bulimia is about 2% per decade. And then as far as anorexia goes, again, greater than 5% of patients die within 4 years of their diagnosis. Eating disorders overall are the second most deadly psychiatric illness, secondary only to opiate use disorder. And every 52 minutes, someone dies of an eating disorder. As far as quality of life goes, I feel like this is something in medicine that is really hard to quantify, but this is a huge, as someone who had an eating disorder, this is a huge thing that a lot of people, I feel like might pass over. So a significant impact on both the patients and their caregivers' participation and productivity in education and work. A lifetime history of an eating disorder leads to a significantly lower quality of life via this study that they did, and reduced capabilities in several areas of social functioning. More interestingly, they found that even with recovery from an eating disorder, the psychological well-being did not improve up to the level of healthy controls. And then other specified feeding and eating disorder actually had the worst scores compared to the general population for emotional and psychological well-being. And then anorexia and bulimia significantly scored lower in the social well-being category. Stallworth usually says, let's get COVID off the table. Unfortunately, that is not something that we can do with eating disorders. So during the time of COVID, there has been an unprecedented increase in the demand for child and adolescent eating disorder services. The USA diagnostic incidence of eating disorders increased 15.3% from 2019 to 2020 with kind of the onset of the pandemic. And this primarily related to female adolescents and the diagnosis of anorexia. Also, during COVID, experienced clinicians have perceived a higher symptom severity. So not only are there more eating disorders, they've found that they are potentially more severe as well. And they relate this to the more frequent use of social media, as we touched on in the prevalence page, a longer duration of exercising, more restrictive eating, and a perceived lack of control along with all of the COVID adventures that are going on. In addition, COVID shutdowns resulted in the loss of some treatment options with lockdown. For example, one of our intensive outpatient programs here in town shut down with COVID and has yet to reopen. And then there's a big push to go to the virtual healthcare, but there's a suboptimal ability to monitor meals and weight via telehealth, which proves to be a big problem for eating disorders. All right, rapid review, DSM-5 style. So anorexia nervosa. So overall, it's the restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. There's also an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain. There's also a disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. And within anorexia, a lot of people just think of the restrictive subcategory, but there is a binge purge subtype as well. Diagnosis pitfalls for anorexia. So there is no absolute weight or BMI cutoff for diagnosis anymore. That was, there used to be like, some of those in the DSM-4. The DSM-5 has completely taken that out. And so that can make things a little easier or harder to diagnose depending on which side of the spectrum you fall on. Amenorrhea is also no longer required. There were some studies that showed that not all patients with anorexia had amenorrhea, and plus that kind of takes out the whole male category of patients because they don't have periods to start with. Adolescents and children may not realize their fear of weight gain until it occurs, and then many patients underestimate the severity of their illness. Other pearls for the diagnosis of anorexia nervosa: weight loss is often viewed as an impressive achievement and a sign of extraordinary self-control, whereas weight gain is perceived as an unacceptable failure of self-control. Also, it's important to obtain collateral information from parents and caregivers, as patients often lie and are not aware that their behaviors are atypical. Although this is also hard because there's a lot of secrecy and hiding in eating disorders, and so that could be hidden from their caregivers as well. They can engage in excessive or compulsive exercise. Common onset is with the body changes of puberty, and then they generally have very rigid kind of black and white thinking patterns. And there's an absence of expected decrease in energy levels, which is a little interesting. So normally you would think if somebody is restricting their intake that their energy levels would be low, and they have not seen that in anorexia. They've actually seen an opposite of that. So they maintain those high energy levels, the exercise, all of that, despite their severe malnutrition. All right, bulimia nervosa. So this is recurrent episodes of binge eating, recurrent inappropriate compensatory behaviors, and they happen at least once a week for 3 months. So a binge eating episode is eating in a discrete period of time an amount of food that is definitely larger than what most individuals would eat in a similar period of time under similar circumstances. So once again, nothing super concrete as to what exactly qualifies as that. And they also need to have a sense of a lack of control over eating during that episode. As far as compensatory behaviors go, a lot of people think of the self-induced vomiting, but this is actually can be pretty much anything that they engage in to try to get rid of that nutritional intake. So self-induced vomiting, misuse of laxatives or diuretics or other medications, even fasting or excessive exercise. And then additionally, the self-evaluation is unduly influenced by body shape and weight. So some diagnosis pitfalls. The binging often occurs in secret and is embarrassing or distressing to the patient. So it's really difficult to detect this a lot of the times. And as we kind of talked about, the purging does not only involve vomiting or laxatives. Pretty much any compensatory behavior counts. And then big pitfall that a lot of people can fail to realize is that most patients with bulimia have a normal or even elevated BMI. Other pearls, so it's often cyclic in nature between the binge and purge cycles. And the problem is that it's kind of this self-perpetuating cycle. So they binge and then they do the compensatory behaviors and then they binge again because they've been essentially malnourished and starving themselves. And then there's more compensatory behaviors. And so it just keeps going in a cycle. Those with bulimia, even if they're not underweight, can have menstrual irregularities as well. And they can have wide swings in weight due to the binge purge cycles. Something that we do learn about in med school a lot of the time is Russell's sign, which is the calluses on the knuckles from self-induced vomiting and poor dental health, but that only applies to those who are self-induced vomiting. ARFID, so this is avoidant restrictive food intake disorder. So this is an eating or feeding disturbance as manifested by persistent failure to meet appropriate nutritional and or energy needs associated with one or more of the following. So they either have significant weight loss, or remember in children that counts as a failure to achieve expected weight gain, so a falling off on the growth chart essentially. Significant nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, or marked interference with psychosocial functioning. So diagnosis, pitfalls, and pearls for ARFID. So this is seen a lot in patients with autism, actually. And so when the eating disturbance occurs in the context of another condition or disorder, such as autism, the severity of the eating disturbance has to exceed that routinely associated with the condition and warrant additional clinical attention. So a lot of patients with, not every patient with autism is going to get an ARFID diagnosis. A lot of them have texture sensitivities in that, but the patients who are really severe can qualify for a diagnosis of ARFID. The other big important thing about ARFID that differentiates it from anorexia is that there's no evidence of a disturbance in the way in which one's body weight or shape is experienced and no fear of gaining weight or becoming fat. So keeping in mind that, as I stated earlier, children sometimes fail to realize their fear of gaining weight until you start refeeding them and they start gaining weight, and then they can have a little freak out moment. And that would be more typical of anorexia. Other specified feeding and eating disorders. So this is kind of the leftover kind of catch-all category for individuals who experience significant distress due to symptoms that don't meet the full criteria for a diagnosis of either anorexia, bulimia, or ARFID, or some other ones listed at the bottom that we're not necessarily talking about today. So atypical anorexia nervosa, basically they meet the criteria for anorexia, except that they don't have what would be considered a low weight for age. And so this can be obese patients who have lost a lot of weight, or it can be so that their weight is still within the normal category, but they still have all the rest of the typical manifestations of anorexia. And then bulimia nervosa of low frequency or limited duration. So if they have had it for less than 3 months duration, or if it's less than once a week on average, they can qualify for this diagnosis. And then there's binge eating disorder of low frequency. There's a purging disorder, which does not have any binging associated, and then a night eating syndrome as well. So pearls about OSFED. So it's estimated to be the most common eating disorder diagnosis overall. And atypical anorexia nervosa has similar medical complications to anorexia nervosa, despite them not necessarily having the low weight. And just because it's an OSFED diagnosis doesn't necessarily mean it's less serious than full criteria eating disorders. There's a few other ones that are mentioned in the DSM-5. So there's an unspecified feeding and eating disorder. It's used when an eating disorder is present, but the clinician doesn't have complete information to categorize, such as like an emergency department provider who's seeing someone and they don't have time to go into exactly what the pathology is. There's also binge eating disorder, pica, and rumination disorder. One other thing I did want to mention is RED-S, which is relative energy deficiency in sport. And so this is basically the expansion of the female athlete triad. And so what it is it's either intentional or unintentional failure to meet the requirements of their physical exercise. So basically what they're taking in is not making up for what they're putting out in their sports. This can be related to an eating disorder, or it can be related to just disordered eating. And so that's kind of a confusing one, disordered eating versus eating disorder. And so disordered eating is just that the eating patterns are not necessarily what we would consider something normal, but it doesn't necessarily cause them a lot of problems or have the underlying pathology. So it can be more unintentional usually than an eating disorder. And so this goes, your amenorrhea, your bone density, and your disordered eating is what the female athlete triad is. And this one has a bunch of extra circles that come into the center. So if you're interested in that, there's more to know about that. All right, let's talk about detection of eating disorders. So eating disorders are obvious, right? Well, not really, okay? So these patients, they have a natural tendency to hide, lie, and isolate. They're usually very high achieving, very high functioning patients. They don't generally have the physical or medically recognizable effects until their eating disorder is very severe, and some patients never even get to that point. But that doesn't mean that they're not having severe disturbances in their quality of life to go along with it. Eating disorders can occur in all body types and BMI ranges. And the hard part about eating disorders is that it's really more about the cognitions and the behaviors than the medically recognizable signs, which can make it really difficult to detect in your office. There won't necessarily be any vital sign or lab abnormalities, but it's all kind of about what they're thinking in their head and the reasons for why they're doing what they're doing. Some risk factors that have been discussed for eating disorders. We don't have any evidence that shows us exactly what the cause of eating disorders are, but some things that have been associated with eating disorder development is aesthetic or weight-conscious sports such as dance, gymnastics, figure skating, and wrestling. Also having a first-degree relative with an eating disorder. There's an interesting study that showed that mothers with current or histories of eating disorders had poor awareness of hunger and satiety cues in babies, and even within the first 6 months of their life was much more concerned with, is my baby overweight? And then also stressful life events. So moving, sports injuries, divorce, anything like that. This can be developed as kind of a coping mechanism. For anorexia nervosa in specific, you increased risk if you have an anxiety disorder or obsessional traits in childhood. For bulimia, weight concerns, low self-esteem, depressive symptoms, social anxiety disorder, and over-anxious disorder of childhood can all play a role into the development of bulimia nervosa. And it's also been found to be secondary potentially to childhood sexual or physical abuse. So things to think of if you see these patients with these issues in your clinic to keep in mind an eating disorder later on. Interestingly enough, bullying, there's insufficient evidence for a causal relationship, but it was found in one study that the bullying may actually be more of a result of the eating disorder behaviors and isolation than an actual cause of eating disorders in patients. All right, in the primary care setting, so screening for eating disorders, the AAP recommends asking questions regarding body image, dieting, and changes in exercise or eating habits. And so I like this picture because it just reminds us that screening is not necessarily saying like, yes, you have it and no, you don't, but it's kind of categorizing people into, yep, probably not, probably so, or we need more investigation. So one of the first things that pediatricians look at is growth curves. And so as we know from our little babies, our failure to thrive babies, generally the weight falls off first and then the height can fall off if it's more severe malnutrition. BMI can be the best for growing children, as weight changes alone may be underwhelming because most children are still growing. So even if their weight stays the same, but their height increases, it's going to drop their BMI, which you won't necessarily see on just a weight curve. However, it's not always revealing, as the eating disorders are, like we talked about, more about the cognitions and behaviors than the weight, especially early on. So it's really important to look for trends rather than just straight percentiles. All right, so here's a lovely growth curve we have here. So this is a Hispanic male patient, actually, probably not what you think of when I say eating disorder necessarily, who was obese and had some pretty dramatic weight loss via some not so healthy mechanisms. And as you can see, this went on for quite a long time before he received the help that he needed and started having some resolution of his weight loss, actually. So that's kind of an interesting one for you. This is kind of a more typical anorexia nervosa growth chart where they're just kind of below and then they kind of fall off. And so this was a female patient with anorexia nervosa who, as you can see, just has lots of weights down kind of underneath the growth curve and even then had a kind of a falling off in the middle before jumping back up a little bit, but still has not made it back to the growth curve. And then this one's a rather interesting one. So looks okay when at first glance, right? Everything's kind of, in a decent percentile. But if you look towards the end, there's a lot of kind of ups and downs and also a stagnation of the BMI and a drop at the end. And so this is actually a patient with bulimia who had kind of the ups and downs of eating disorder, weight. And if you look, it kind of goes into the college age, and that can be a big precipitating factor for patients is when they move to college. That can sometimes change their eating disorder or kind of push them over the edge. All right, another important thing is amenorrhea or oligomenorrhea. So it's commonly present in about 33% of patients with atypical anorexia nervosa, so not even those with low body weights, they had secondary amenorrhea. It's a big indicator of physiological dysfunction, and so it may precede weight loss or present as delayed menarche. So something else to think about in your patients who are approaching those ages that you're like, why are we not having periods yet? It could be that they have an eating disorder and their weight has never actually made it to that threshold for their body to release the hormones and do all the things to have a period. Patients may deny knowing how many periods they've had. I've found this with patients not only with eating disorders, but other female patients as well. Some of them just don't pay attention, but it's also something to look out for. A lot of patients with eating disorders know that this is something that they can't necessarily control, and they may or may not lie about it. Birth control is basically an artificial mediation of menses, right? So it's not helpful for determining physiological compromise. If you give anyone enough birth control, they'll probably have a period if everything is kind of, in their body. And so birth control is not recommended to regulate the cycle. It does not help with bone mineral density either, which is one of the big irreversible consequences of eating disorders. And it can mask the physiologic markers of recovery, which can make it difficult to know at what weight is an appropriate weight for that patient. So before you start someone on birth control for irregular menses, this is probably something to consider. All right, screening questionnaires. So here are two of the shorter screening questionnaires. So the SCOFF questionnaire was originally made in the UK, so that's fun. So when you see 1 stone, nobody really knows what that means, but they put it into kilograms here for us. So S, do you make yourself sick because you feel uncomfortably full? C, do you worry you've lost control over how much you eat? O, have you recently lost more than 1 stone or 6.35 kilograms in a 3-month period? F, do you believe yourself to be fat even when others say you are too thin? And F again, would you say that food dominates your life? And so an answer of yes to 2 or more of the questions warrants further investigation. There have also been 2 additional questions that are related to bulimia nervosa. So are you satisfied with your eating patterns and do you ever eat in secret? And that can be both for bulimia and kind of binge eating as well. As far as the EDEQ goes, so this is the Eating Disorder Examination Questionnaire. The QS is the short form, so we'll get to the full form in a minute. But this is a little more detailed, and like I said, this is kind of condensed from the 3-page version, but has been shown to have good screening qualities in it. So looking at some of the questions there, you can kind of see how that would go about leading you potentially to an eating disorder diagnosis. This is another one that I found that is probably a little less frequently used. However, this is more looking at like ARFID type pathology. So it's less about the body and, weight and that type of stuff, but more about kind of the aversion to food that you would see with ARFID. So this one might be more helpful for trying to decide, within a kiddo, do we have more ARFID or do we have more anorexia or what is going on here? So this can be a helpful tool as well. All right, as far as further investigation goes, so once you've done your screening and you think that this patient, may have an eating disorder or you feel like you need to look into it further, this is the Eat 26. And so this is a questionnaire about, it's the eating attitudes test, kind of looking at how the patients feel about food. And it doesn't necessarily have a strict cutoff for like above this score is an eating disorder, below this score is not, but it's used more for trending in treatment. And so you look at the score and then you can do this periodically and hopefully that score is dropping as they're improving from their eating disorder. Here is the full EDEQ that we talked about. So this is generally, this is a questionnaire that it was made from the actual EDE interview that is considered the gold standard, but the questionnaire has pretty decent sensitivity as well. So a global score of greater than 3 when you average it out is used for Medicaid diagnostic eligibility as far as treatment goes. But kids with anorexia will usually have a score of 4 or higher. And each of these categories, kind of broken up by the bold lines, kind of go into the different sections of eating disorder pathology. The one study did say that was only 60 to 75% sensitive, which is a little concerning for a screening and diagnostic tool. So just because you don't have a positive result on the EDEQ doesn't necessarily rule out an eating disorder, but it can be a good thing to look into, ask kind of some of those further questions to investigate. All right, in the emergent and urgent care setting, so some things that kids will come in with is syncope. And so this is a common symptom of eating disorders due to malnutrition, orthostasis, dehydration, and or excessive exercise. So the orthostasis is actually present in 43% of atypical anorexia nervosa patients. And like we said, those are the patients who don't even have a significantly low weight. So that can be something to look out for. And this is, we kind of joke about it and talk about Girl Fall Down Clinic and all the things, right? But this is something to look at when you have someone who comes in for a syncopal episode. Another thing you can run into is arrhythmias or more commonly bradycardia. So electrolyte abnormalities if purging or abusing laxatives or diuretics. It's most commonly potassium or chloride. And then bradycardia for malnourished patients. So once again, even those patients with atypical anorexia had about 24% of them had bradycardia. And so interesting story. I was working in the ED in Des Moines and we got report of a patient coming in, a teenage patient with a heart rate of 40. And we said, oh no. And we started setting up the room for a code and the whole works. And we're like, this is not going to be good. This is terrible. And in walks the patient. And she goes, hi guys, how you doing? And I said, oh, okay. So yeah, her heart rate was 43 while she was up and walking. And she had a diagnosis of anorexia nervosa. And her school nurse had checked her pulse and had a little freak out moment fairly appropriately and sent her to the emergency room. Other complaints that you might find in the urgent or emergent care setting, GI complaints. So hematemesis, esophageal tears, and gastric rupture can be seen with binging and purging. Rectal prolapse can be seen especially with misuse of laxatives. And then constipation is a common complaint for patients with eating disorders. I always say what goes in must come out. So if there's not much going in, not much is going to come out. And then malnutrition can actually slow down the GI tract as well and lead to constipation, not to mention some evidence of dehydration as well. And then vomiting is not necessarily something that a patient's going to come in with and say, oh, I'm vomiting, right? But this could be something that either parents or caregivers or somebody is seeing in a patient that might bring them into your office or your emergent setting for evaluation. And so anyone who's vomiting a lot, that can be a wide differential as we know, but something to keep in mind is something like bulimia or purging, which can be seen with bulimia or anorexia. All right, treatment overview of eating disorders. So common comorbid conditions. So this is a nice little graph that shows that eating disorders hardly ever occur in a vault. So about 70% of patients with eating disorders had depression, 63.5% with an anxiety disorder, 41% with OCD, 20% with social anxiety disorder, and then another fraction with PTSD and panic disorder. So kind of, some of these that we think of, so depression, anxiety, OCD, and body dysmorphic disorder is another one. All are pretty much inherent parts of eating disorders, right? So if we looked at the diagnostic criteria, they have undue concern about their weight. They have, a lot of time fears about food, so lots of anxiety. There's a lot of depression that goes along with it, which can be either present before they lose weight or even just a, kind of a a result of weight loss itself, and being malnourished can lead to higher depression scores. And then body dysmorphic disorder is generally not seeing your body in the way that it is. And so for these, they can be diagnosed with an eating disorder, but generally just if those behaviors only pertain to the eating disorder, you wouldn't necessarily give them an outside diagnosis of any of these. So you kind of have to look for if it extends into other areas of life, and then you can consider diagnosis and treatment for those comorbid conditions. Big thing is, don't forget about your suicide risk in these patients. So making sure that you're doing your suicide screening and safety planning. Substance use disorder, this is something that, we don't necessarily see a ton. It's more common in the adult patients with eating disorders, but it can commonly co-occur as a self-medication for anxiety, depression, or as a distraction from food and hunger. So there's also kind of this chicken versus the egg, because if you look at a lot of alcoholics, they're not eating great, right? And so that could potentially be seen as an eating disorder as well, or be considered for evaluation of an eating disorder, but it's hard to tell. And then things to keep in mind, so diet pills and stimulants may be abused by patients with eating disorders in an attempt to lose weight. And if you've been down the dieting aisle at Target lately, you know that they are right there on the shelf, easy to get, no prescription needed, just grab them off the shelf. So what to do if you have a kiddo in your office and you have concerns for an eating disorder? So I would recommend completing the EDEQ, which is what we kind of consider to be as good of a gold standard as we have, and or the EAT 26 after you've done some of those screening questions, right? Obtain a urinalysis for hydration status, as many of these patients can be very dehydrated. Get a blind weight in a gown and underwear only. Make sure you get orthostatic vital signs, because that's going to be positive in a lot of your patients, but not in all of them. They recommend getting a CMP, a MAG, and a FOS for electrolytes, a CBC for neutropenia or anemia, which can be found in severe malnutrition, a TSH and free T4 to rule out organic disease, and then an amylase and lipase if they're vomiting. They also recommend an EKG to look for arrhythmias and bradycardia. And then it's important to work on a prompt referral to an appropriate level of care. We'll talk a little bit more about the levels of care in a minute. With eating disorder experienced providers, right? So general medical wards for medical stabilization, behavioral health ward for suicidality if they're medically stable, outpatient therapist, dietitian, or start a referral process to an inpatient eating disorder specific treatment center. It's recommended, just like with your failure to thrive kiddos, right? We see them a lot for weight checks. And so this is the same type of thing for patients with your eating disorders. So very frequent appointments for medical and weight monitoring. Some of these kids will just stop eating, especially if they have a freak out moment after they've been diagnosed or found out, and they will kind of go off the deep end, stop eating, and they can just boom down that bad path. So important to keep up frequently with them. And then one of the other recommendations is to consider a DEXA scan if the patient is amenorrheic for greater than 6 months. And that's looking at bone density again, which is an irreversible complication of eating disorders. So who do we need in the treatment team of a patient with an eating disorder, right? So it's not going to be just you as the primary care doc. So generally the medical doctor is in charge of monitoring for medical stability, generally coordination of care, and medication management if that's indicated. And we'll talk more about medications in a minute. You definitely need a therapist. This is for addressing the underlying concerns, those comorbid conditions, and dealing with or developing coping strategies. FBT is actually family-based treatment, also known as the Maudsley method, which is generally the first line kind of evidence-based treatment for eating disorders, but this can be really hard to find. A dietitian is also really important. They can do a meal plan for your patient if that's what is needed. They can do a lot of the weight monitoring, and a lot of the times they'll see the patient more frequently than the doctor, and so they can be in charge of that. They can work on food fears and a balanced diet. And then plus or minus a psychiatrist, usually for medication management or diagnosis of comorbid conditions. One thing we didn't talk about earlier is personality disorders, which don't really apply in the pediatric world because you can't really diagnose them before 18, but there are a lot of personality disorders involved in eating disorders as well. All right, CEDS certification. So this is a certified eating disorder specialist. This is something to look for when you're trying to find a treatment team for your patient. And so it's a certification from the International Association of Eating Disorder Professionals, and it requires a bunch of education in eating disorders, as you can see here. And so that is something to look for. Medications. So medications have not been found to increase weight gain or prevent relapse in eating disorders. Boost Bar or Atarax can be helpful for mealtime anxiety, especially for those kids who just have a really tough time eating and they have to get the food in because the medicine for an eating disorder is getting nutrition. Wellbutrin, just a reminder, is contraindicated in anorexia and bulimia because it decreases the seizure threshold. Prozac is FDA approved for bulimia in adolescents and adults, but there are no FDA approved medications for anorexia nervosa. A lot of the time, atypical antipsychotics can be used to augment weight gain, but there's kind of some conflicting evidence on this. And then many SSRIs are actually going to be ineffective at a low weight because of the neurotransmitters in the brain that aren't working properly. And so they're not going to be effective until weight is restored, but they can be helpful with anxiety surrounding the food and weight gain, depression, and suicidality. There are no official recommendations from the organizations. And so basically they say just to consider each patient's case individually as far as medication goes. All right, a lovely little pyramid here of the levels of care for eating disorders. So let's start at the bottom, actually. So that's the biggest chunk because this is where most of your patients are, right? So your outpatient treatment. So this is usually an eating disorder experienced therapist and dietitian with once to twice weekly appointments at the beginning. Sometimes they'll space them out to maybe every other week, but that's where most of the patients are getting care from. Step up from that is the intensive outpatient program, which is approximately 3 hours a day, 3 to 5 days a week, usually includes a meal and some therapeutic programming. PHP, partial hospitalization, is a step up from that. And so that's about 8 hours a day, 5 to 7 days a week, will generally include 2 meals, a snack, and some therapeutic programming. Step up from that is residential. So this is for your stable patients who just can't do well outside of treatment and need that intensive treatment all the time. And so it's not necessarily a medical ward. It's more of it's a residential ward for ED specific long-term care. And then kind of the highest level of care within the eating disorder specialty is inpatient care. And so this is dedicated eating disorder specific short-term acute care. The problem that we run into is that some of our patients show up sick enough that they can't get accepted into the eating disorder specific inpatient units because a lot of those don't do IV fluids. They won't do patients with vital sign abnormalities that can be, deemed medically unstable. And so that's when they show up in our patient ward. Or if they're waiting to get into an eating disorder center, because we'll talk about wait lists and costs and all the things in a minute. All right, so treatment troubles. So availability. So here in South Carolina, there is no eating disorder specific inpatient, residential, or partial hospitalization programs. So the highest level we have in town or in the state is intensive outpatient programming, which is going to be like 3 hours, maybe 3 to 5 days a week. And that is at MUSC. Otherwise, the nearest facilities, if you're looking for inpatient or residential care, Veritas is where some of our patients go to. There's also an eating disorder unit at Chapel Hill, but none of those are in state, unfortunately. There are approximately 2 to 3 outpatient ED experienced therapists in town and 2 outpatient eating disorder experienced dietitians in town. And so that is not a ton of people. And then we run into the insurance issues. So in South Carolina in general, dietitians are not covered by insurance, even for eating disorders. And so those are going to be out-of-pocket expenses for the family, which may or may not be reasonable depending on who your patient is and what their family dynamics are. I also run into a lot of problems with either the dietitians or the therapist not being in network. Now, this isn't necessarily a hard stop, but you do have to petition your insurance company to get them covered. Then you have to pay up front for things and then be reimbursed later after you self-file those claims. And so all of a sudden now you've taken on the role of liaison to said insurance agency. Medicaid is not accepted by some facilities as well, which is a big problem for a lot of our patients who are on Medicaid. And as far as cost goes, one patient did not have insurance coverage of eating disorder facilities, and they wanted $40,000 up front to send the patient there, which is nearly impossible for most patients. Fronting the cost if they're out of network, travel costs to places like, Charleston, and then lodging costs for step-down care. So step-down care would be anything below either residential or inpatient. So those partial hospitalization programs or the intensive outpatient program where you're going to have to stay pretty close to where you're at. And so that limits the ability of what we can do from Columbia. All right, so non-eating disorder specialized inpatient stabilization. So this is like us here in the Children's Hospital, right? So we're not an eating disorder facility, but as we talked about, sometimes these patients need either immediate care because they're unstable or they're not stable enough yet to go to an eating disorder facility, or there's a long wait list. So who gets hospitalized? Generally, a lower percent median BMI, which is one of the big metrics that they look at with eating disorders, those are the patients who get hospitalized. So a history of obesity is less likely to get hospitalized despite a greater percent weight loss. Remember that growth chart we saw where we were way obese and we had an impressive weight loss. And those patients are generally historically less likely to get hospitalized. So those are your atypical anorexia nervosa patients. The rate of weight loss is a significant predictor of medical instability. So it's not necessarily the weight they show up at, but it can be how much weight have they lost. And then it has to be an individualized decision based on the available resources, which we just talked about. We don't have a lot of here, the medical stability and their progress with outpatient treatment. So it's not necessarily just your patients who are super medically unstable. So the AAP has some recommendations on who should be hospitalized. As you can see for anorexia and bulimia, there's a little different, criteria for each, but generally it's some sort of, medical compromise. However, at the bottom, it does show that for anorexia, a refusal to eat in general is a reason for hospitalization, and then failure to respond to outpatient therapy as well. All right, so the goal of hospitalization, so this is medical stabilization of vital sign abnormalities through nutritional rehabilitation with careful monitoring of electrolytes. It's helpful for improving weight, but there isn't a lot of great evidence showing that actually having them here in the hospital is going to fix any of the cognitions or the behavior or the mental and behavioral issues of the eating disorder. The goal for anorexia and ARFID, because those generally present fairly similarly from a medical standpoint, is the medical stabilization and weight gain. And the goal for bulimia is breaking the binge purge cycle that we had talked about, and obviously monitoring electrolytes as well. So refeeding syndrome, this is kind of the big, most feared complication of eating disorder treatment, right? And so it's a multi-organ failure from rapid intracellular shift of electrolytes from increased insulin and increased ATP. And so hypophosphatemia from all the ATP production is generally the hallmark finding. You can also see hypokalemia, which will get you into your heart arrhythmias, and hypomagnesemia, which we all know from the PICU that if your magnesium is not good, you're going to have a hard time correcting your other electrolytes. So always good to check that one as well. They can also develop free water retention, which will present as edema. So the initial weight was more closely associated with the risk of refeeding syndrome, more importantly than caloric intake or weight gain. However, there's been newer evidence that shows that actually the weight loss that they've had can be more important than their initial weight in general. So refeeding syndrome can lead to altered mental status, seizures, and even death if untreated. So underfeeding is one of the other things that is talked about less, but this is kind of what we have to balance the refeeding syndrome with. So initial weight loss was found with hypocaloric diets of 1,000 to 1,200 calories a day. So, and this potentially prolonged or worsened their medical effects of the disorder, and it's potentially even more dangerous than refeeding syndrome, as there have been patients who in the hospital under the care have lost weight progressively, had worsening medical problems, and have actually died. So safe refeeding, the old motto was to start low and go slow, but recent studies have shown that a higher initial caloric intake was associated with shorter hospital stays, no increase in refeeding syndrome, and the ability to return home for that gold standard family-based therapy treatment, because you can't do that in the hospital very well, or to a specialized eating disorder treatment facility for treatment of those underlying eating disorder cognitions and behaviors. But once again, like I said, that it's refeeding versus underfeeding, and it's kind of a fine line on where we're at. So some current recommendations from different organizations and protocols that are out there. So the Academy of Nutrition and Dietetics recommends starting at 1,000 to 1,200 calories per day and increasing calories to achieve a 0.5 to 1 pound weight gain per week. That's kind of one of the more conservative recommendations, likely because it's probably due more to outpatient, not necessarily patients who are in the hospital. So the Aspen guidelines, these are not eating disorder specific, but they're just for anybody who's at risk of refeeding. And they recommend starting fairly low as well, with 40 to 50% of the calorie goal. And then some lab monitoring is recommended over on the side over there. The APA, which is the American Psychiatric Association, recommends 1,000 to 1,600 calories a day to achieve a 2 to 3 pound per week weight gain for hospitalized patients specifically. And they recommend lab monitoring daily times 5 days and then every other day after that until they're stable on full feeds. The CHOP protocol, one of my favorites, not gonna lie. So they start at 1,200 calories per day or 500 calories greater than their usual intake at home. And they increase by 200 to 400 calories per day. Most patients 400 calories per day. And they monitor electrolytes once or twice daily. And then Prisma Upstate actually has a protocol as well. And so for age 12 and up, they start at 1,800 calories a day. If they're less than 12, they start at 45 calories per kilogram per day. And they increase by 200 calories per day for a goal of 1 kilogram per week of weight gain, which is approximately 2.2 pounds, pretty in line with the APA guidelines. And they have their lab monitoring recommendations there. All right, here is the Prisma Health Upstate protocol, my condensed version because it was a long document, if you want to see the whole thing. Generally, big things to bring up is that they recommend telemetry if the heart rate is less than 30 or if it's less than 40 with symptoms. Also, if they have any arrhythmia, a QTC greater than 500, or severe electrolyte abnormalities. And so this is not really going to be a ton of your patients. Getting heart rates down to that low and even heart rates above that, your nurses on the floor are probably going to be uncomfortable with, but talking to them can be helpful. And then a little farther down, we talk about the actual eating protocols. So basically the patients get a standardized tray brought to them. They have 30 minutes to complete their meal or their snack, which is observed by a sitter to make sure they're not, disposing of any food, anything like that. And then after their 30 minutes is up, you take what's left on the tray, calorically transcribe that into like a boost supplement, and they have 15 minutes to drink that. If they are unable to finish it in that amount of time, that's when you start considering NG tube feeds, because that shows us that we're not going to be able to meet our nutritional requirements to get better from the eating disorder. And then activity level. So they recommend bed rest only if they're medically unstable. So our last patient like this had a lot of syncopal episodes. And so it was really important for them to be somewhat on bed rest and have really monitored bathroom trips and all of that, because we had some syncopal episodes with them. But their standard level of activity is about 3 laps 3 times a day around the peds ward. All right, here's the CHOP protocol. So I highlighted kind of some of the more important things that I feel like anyways. So big things to note is that they accepted a lower calorie goal for patients who have a history of purging behaviors, as if not to push them over the edge into their purging activities. They recommend starting at 3 meals a day and advancing to 3 meals and 2 snacks by discharge. They do the same 30 minutes for the meal, 15 minutes for the supplement, and after that, considering NG feeds. Interestingly enough, and this is very true of most of the inpatient eating disorder centers as well, there's no food preferences. So a lot of patients with anorexia and eating disorders will cut out entire food groups and be like, nope, I'm not going to eat that. And so those dislikes are not generally honored unless they're true allergies with some proof. And then vegetarianism is another thing that a lot of patients with eating disorders will do. They'll be like, oh, it's a socially acceptable way to cut out groups of food. And same with gluten-free and that type of thing. So this recommends that we don't do any sort of food preferences other than allergies. It does have some recommendations for replacing electrolytes with levels there. And then the parental involvement is a big one, right? So we talked about the family-based therapy being the gold standard for treatment. And so this is a lot of getting the parents involved, right? Because essentially our goal is to get these patients home, which is with their parents, and their parents are going to be somewhat in charge of meal planning, making sure they're eating, monitoring them, supporting them through their meals. And so that's really important as well. So they generally recommend that at 72 hours of hospitalization, the parents take over most of that observation of the meal periods and the time after the meal periods to watch for compensatory behaviors. All right, so the overall goal of non-specialized inpatient stabilization is to balance the refeeding syndrome with underfeeding. Generally, 1,200 calories a day is considered safe as a starting point, increased by 200 to 400 calories a day, and goal of up to 2 to 3 pounds per week of weight gain. You want to stabilize their vital signs, including the bradycardia and the orthostatics, and the best way to do that is with nutritional rehabilitation. And determine next treatment steps, so the level of care that they need. Where are they going when they leave your facility? Can they go home and do outpatient treatment? Do they need to go to a specialized center? Do they need one of those intermediate stages of IOP, PHP, something like that? And if so, we don't have those available here. So how do we get them to that? And that might end up with you picking a higher level of care for them because we don't have those available here. All right, what are we working for in eating disorders? Recovery and unfortunately relapse, right? So what is recovery? So there's kind of varying definitions of recovery. Generally, it includes weight restoration, eating disorder behavior abstinence, and resolution of the cognitive symptoms. So goal weights is a big part of eating disorder recovery, and it's kind of a really tricky thing to figure out. You got to look at the growth curves and where they've been and where their periods come back and where they're physiologically back to a baseline. And so that can be a really difficult thing to figure out, and generally something that you might want to defer to some people with some eating disorder specialty knowledge on. Also return to social engagements and resumption of full physical activities. As we talked about, a lot of the times they kind of withdraw from society and just kind of get stuck in their eating disorder. And so drawing them back into society can be really a good indicator of recovery as well. And then there's some mixed evidence, but some evidence supports earlier detection with a shorter time frame to recovery, which kind of goes at, they're kind of sneaky onset. So if we can pick them up earlier, get them into treatment sooner, that might potentially shorten their duration of illness. And then severe and enduring eating disorder is kind of a new emerging diagnosis that's generally diagnosed after 7+ years of illness duration and multiple unsuccessful treatment attempts. So recovery generally includes weight restoration, and this has been true of patients even if they're not grossly underweight. So remember our patient, the growth curve that was really high on the growth curve, really high BMI, came down. Even there would be a lot of argument that that patient needs to gain some weight back as well in order to get out of kind of the malnourished state and restore kind of the cognitive abilities and all of that to go with it. My best advice for eating disorder recovery is faking it until you make it. So these kiddos, they don't want to eat, they don't want to do the things, and it's not going to get better until their nutritional status is improved. And so you just gotta eat and fake it until you make it and you get better. Resolution of the cognitive distortions, a reevaluation of their core beliefs, which is kind of getting deep into therapy world, and then finding an identity outside of the eating disorder. So most of these patients have been stuck in their eating disorder and that's all they do and all they think about. And so trying to draw them out of that and find other things that are more worthy of their time can be helpful. Relapse is the return of eating disorder symptoms or pathology following a period of complete or partial recovery. Super common, unfortunately. Only about 50% of patients with anorexia nervosa fully recover. 30% partially recover, 20% remain chronically ill. And then for bulimia, 80% of patients achieve recovery, but 20% relapse. So triggers can be self-comparison, low self-esteem, and stressful life changes or events, especially moving to college, right? So we're changing medical care teams, we're moving places, we're out on our own without our parents. And so that can be a big time when patients who have either had a history or a current eating disorder can have kind of a bad downtrend. All right, back to our questions. So which of the following is not a DSM-5 criteria for anorexia nervosa? The answer is amenorrhea. So that was taken out in the DSM-5 rendition for reasons that we spoke about, but the rest of these are diagnostic criteria. The best approach for inpatient medical stabilization of a medically compromised patient with an eating disorder includes giving observed balanced meals with incentives for completion, whether that is child life being involved and giving them those type of incentives, or kind of the negative incentive of if you don't finish it, you're going to get an NG tube and get feeds that way. And then atypical anorexia is less serious or dangerous than anorexia nervosa. False. So they can have just as many of the medical complications as patients who fit the full diagnostic criteria for anorexia nervosa. All right, here is the grant or the CME thing, my bazillion sources. And then I will leave you with a slide on local resources as well. So this one. Okay. All right, questions. Chelsea.
So I know we see this a lot in chalk. We have a kid who comes in morbidly obese, and you kind of have to have the discussion of, stuff like diet, kind of losing weight, that kind of stuff. How do you, I guess my question is, how do you phrase it in a way so that next time you see them, because we've had kids come in 2 to 3 months and they lose a ton of weight, like how do you balance that discussion?
Oh, yeah. So the question was, especially our patients in shock, they come in, they're obese, and we have all these talks with them about the stoplight diet, how important it is for them to lose weight, change their eating habits. How do we not push that into development of an eating disorder, essentially? And so they're very timely. There's some new peds obesity guidelines that just came out that are striking up a lot of conversation in the eating disorder world as well. I have not personally read them, so I cannot comment on them, but that is kind of the fine line that we walk, right? And so these patients do need to lose weight. They do need to develop, healthier lifestyle practices in order to avoid some of the medical problems with being overweight or obese. But I think, it comes back to the cognitions again, right? So the cognitions and the behaviors. So are they doing it in a healthy manner, right? So water fasting, no, not a healthy manner, right? Purging, overexercise, those types of things. So it's kind of everything within, a reasonable amount. As for what is too fast of weight loss, that's kind of where I run into problems, right? So we just told them to lose weight. Now they're doing it. Great, right? Oh, crap. What if they're going too fast, right? And so I think that, again, goes back to how they're doing it and what their reasons for doing it are.
And then, what was the question about obesity?
Mhm.
Yeah. And so then just, highlighting as a pediatrician, health, kind of what you just said, healthy eating habits and healthy physical activity, and not pushing diet so much, I think.
Correct.
What do you do with somebody who is a really successful runner or athlete and, is competing at the top levels, yet they, have delayed physical development and that sort of thing? How do you do that? Because, we've got conflicting issues here.
So question was, especially in kind of your high level, runners, for instance, or athletes who are really at the top of their game, but have some really big red flags for likely eating disorder behaviors. How do you get through to them that maybe what they're doing is not necessarily healthy or the way to go about that, especially when they're feeling their best, they're at the top of their game. And I want to say that personally, I feel like that peak is a very slippery slope to get to that peak and not fall down the other side. Because I've been there and fallen off the edge, and it is not a great place to be. And so kind of getting on those earlier and you kind of going at it from that, remember the red S, the relative energy deficiency in sport. So just talking to them a lot about, making sure that we are, our body is our tool and that's what we're using it for, but we still have to give our body what it needs as far as nutrition, proper nutrition, rest, right? Hydration, all of those things. And so that can be hard. And a lot of the times we do end up pulling these kids out of their sports in order to preserve their weight gain, like you said, even their height can fall off, their puberty can be delayed, all of those things. And so that is definitely a really difficult situation. And so looking, especially for a teenager who's in their high school sports and they see high school sports and that's it, right? And they don't necessarily see the rest of their life, talking about the bone mineral density, all of those things, right, that are going to follow them for the rest of their life, may or may not kind of convince them that there is something to be worked on there.
And then I think too, with the, if they're not yet doing other behaviors, you can just get the help of an outpatient dietitian who may or may not specialize in eating disorders, just to help with the healthy balance of being an athlete and putting the calories back in a healthy way. Because the dietitians, I know the ones who are on the eating disorder team that I worked with also just worked with athletes too. So you don't have to employ the whole team.
Nope, you're good. So Dr. Amarnath just put in the chat that, word of caution in those patients that you're considering anorexia or ARFID, make sure that you rule out organic disease such as IBD, right? Because that can present a lot like your anorexia. And so not necessarily just jumping first to an eating disorder diagnosis. And that's why it's really important to look at, again, what are the reasons for what they're doing? Are they really not eating much because they're afraid? Are they cutting out certain food groups? Are they over exercising? Or does all of that seem pretty kosher and you need to go look down the route more of the medical organic pathology? Scott.
So if you're more concerned about like an ARFID picture and less an anorexia picture, and you're in the outpatient setting, is there any indication for like appetite stimulating medications such as Periactin, or is that frowned upon because that's kind of putting a Band-Aid on something? I don't know.
So, I think you got to do what you got to do, right? So, if that is something that's going to get these patients to gain weight and that's what you need and is going to keep them out of the hospital, and if you can get them to eat with that, that's great, right? I think you still need to address the underlying problems. But if you need that as a temporary Band-Aid, I think that is, not necessarily frowned upon. I didn't come across a ton of research regarding that necessarily, but that would be my personal thoughts. And then big thing for that is getting speech therapy involved so they can do feeding therapy actually and work with these kiddos to desensitize them to the textures and all of that and expand kind of the foods that they'll eat. And so that can be a really important thing, kind of the blast off method, if anyone's heard me talk about that before, for ARFID, but that can be a big one.
Keep putting her out of the way. And with ARFID, one of the, she gave a good example of autism outside the norm of autism. Another good classic example that you might see in the literature, but also we saw a couple at the, a couple of patients back in the residential day when we had one here. We had a 7-year-old who ate a ton of nachos at the same time. I guess a GI bug was cooking in her system. And so then she threw up from the GI bug, but she threw up all of those nachos that she had. So now, because she was also 7 and that's kind of a prime time for anxiety, she developed paralyzing fear of eating, that she was going to throw up again. So it's not like that I don't know what Dr. Guyton might say about about the appetite stimulants for ARFID, but it's not that they are not hungry. They just are scared of it throwing them.
And it can happen after a choking episode as well as another big one. And generally your ARFID patients are a lot younger than your patients with anorexia or bulimia. So that can be another kind of tip off. Not that you can't have an early onset anorexia, but generally, like she said, they're younger, kind of the 7-8 range, or even younger than that.
I forgot about the choking one. Yeah, that is another classic.
Anybody else?
And I will plug too, with the level of care, calling any of these people on the resources or any out of state person, they are so helpful, and they're not in it to make money because it's not a money making business. So if you are ever concerned about what level of care your patient may need, you can just pick one and call them and and they screen with you over the phone your patient and what level of care they think, and that if it's not a fit for outpatient, then they will tell you what the next resource would be for you and your patient. So if you're staying here in South Carolina, or if you're going out of state after you graduate, I can't plug how helpful they are just over the phone triaging your patient.
It's generally a pretty small community and they're aware of the resources a lot more than you might be as a general pediatrician. One more comment from Dr. Amernath. He did say that ARFID patients, you got to look out for EOE as well, right? So if they're having some of that dysphagia or even just problems that it won't go down or it gets stuck, that can look a lot like an ARFID eating disorder as well.